Hello and good morning, everyone out there in webinar land. Thank you for joining us this morning on Wednesday. My name is Jeff. I'm the Director of Insight. It's my great pleasure to welcome you to our first webinar, Insight APSAD webinar for Semester 2 2025. Before I go on, I'd like to acknowledge the traditional owners on which we're gathered, both here in Mianjin, on Yagara and Turrbal land in Brisbane, but also to all of the lands upon which you may be joining us here today and pay respects to elders past and present. I'd also like to recognise the role of lived and living experience in our sector and their journey along with carers, families and others in responding to this population with care and empathy and collaboration. To kick off today, we have Professor Jonathan Brett, who is a senior staff specialist at St Vincent's Hospital and a clinical toxicologist with the New South Wales Poisons Information Centre. And he is here to talk to us about the fascinating topic of psilocybin-assisted psychotherapy for methamphetamine dependence. As per usual, you can type your questions or comments in the chat and we will look at them and answer them either as we go or at the end. But apart from that, I'll throw it over to you, Jonathan, to take it away. Thank you.
Thanks, Jeff, and yeah, thanks again for having me. I've been I should have updated my title there. I've been promoted to professor now, but anyway, thanks for having me back. I think you might remember that I did a presentation for you, I think a couple of years ago on this topic, and that was before we'd actually finished this study. So it's a pleasure to come back to you and talk to you about the results of this study. But before I go on, just like to acknowledge that I'm meeting on Gadigal land and pay my respects to elders past and present here as well. So psilocybin assisted psychotherapy, very topical at the minute. There's a lot of attention in the media, and there's a lot of research going on as well. Really, it's a pleasure to talk to you about this today. So I always try and start these talks by emphasizing that really this kind of modality of treatment is very much about the therapy. um, because it's easy to get distracted by the fact that we're using psychedelics. And I will talk about, some of the mechanisms of how we think they might work, but still, from all the therapy and all the participants we've had through, it's what the thing that strikes me about this kind of work is it does take still an awful lot of work from the people going through it, seeking recovery, and also the therapists, to actually see good results, see results. So it's not a quick fix at all. It still requires a lot of mountaineering kind of work. But you'll see we've seen some pretty good results. And so if the work happens, that's the work in psychotherapy happens that can kind of be accelerated by psilocybin or a psychedelic, then you can get to the top of the mountain and have some beautiful views. So what are we talking about? So the psychedelic that we've been working with the most at St. Vincent's in Sydney is psilocybin. And psilocybin actually occurs naturally in mushrooms. I think most of you probably know that. And there's over 200 species of psilocybin mushrooms. So the psilocybin's a prodrug. It's metabolized to psilocin very rapidly in the body, and psilocin binds to serotonin receptors. So predominantly this 5-HT2A subtype of receptors, but it does act on other subtypes of serotonin receptors as well. Effects can be detectable probably down to about 3 to 5 milligrams of a dose. That's not 3 to 5 milligrams of dried mushrooms. That's of pure psilocybin. Anything sort of around that dose or slightly less, we'd consider a microdose. Anything where you're just getting sort of detectable effects is kind of called a mesodose. But the kind of doses that we've been using in most clinical trials have been at least 25 milligrams as the sort of active arm of the trial. And that's equivalent to about 3 to 4 grams of dried Psilocybin cubensis mushrooms. So when you swallow it, about 50% of the psilocybin actually gets into your bloodstream. And as I said, it's rapidly metabolized to psilocin, which is the active compound. So these days, so we did all of our trials using psilocin that was psilocybin, sorry, that was made in a laboratory. But these days, there's a lot of companies that are kind of similar to medicinal cannabis companies that are springing up that are purifying psilocybin from the mushrooms themselves. So what's actually going on in the brain? What's happening when you take psilocybin? So, like I say, the psilocin and LSD and DMT mainly bind to 5-HT2A receptors, and these are in the cortical pyramidal neurons. So that's in the neurons that really are in the surface, on the surface of the coating of the brain or the cortex. There's some with some other drugs like ketamine, PCP, there are some subcortical effects as well. But I think you'll see there's some really interesting science coming out around kind of the mechanism of how these drugs actually sort of function in the cortex to alter consciousness. So there's a whole range of other psychedelic drugs that have been looked at and trialed in psychedelic assisted psychotherapies. So we've talked about psilocybin, but there's also LSD, DMT. So DMT commonly used in a sort of few different forms. So there's DMT that's either smoked or inhaled. That's very sort of rapid onset but short acting, and that's the red dotted line here that you can see, where the intensity of the effect comes on very quickly and like peaks and then sort of drops off very quickly as well. Compared to things like LSD, which is a sort of, I think, pink, like longer dots, where you can see it kind of peaks a bit after psilocybin and then takes a lot longer to come down, compared to, other things like ibogaine, which is the blue line here, which, takes a few more hours to peak at around 5 hours, and then, really can last a very long time, so up to 24 hours. So, why do we choose, why is most of the research done on psilocybin? Well, it seems to kind of be that sweet zone where, the onset isn't so quick that you're really slamming people into a psychedelic state really quickly, and it's very disorientating for them. So there's some sort of, slowly easing into a psychedelic experience, but then it doesn't act for sort of too long, so you don't have to sit with them for too many hours. Still quite a long time. So there's still really a search or investigation for things that might be maybe a bit gradual onset, but not as long lasting effects. Really to see whether we can get some of the therapeutic effects we've seen so far, but without the sort of time investment from having to the therapist to sit with them for such a long time. But I'll talk a bit about that in a moment. So really, why most of the research is on psilocybin is probably because of these, effects of like slightly slower onset than DMT, but shorter duration of action than LSD and other things like ibogaine. That being said, there is a fair amount of research still looking at inhaled inhaled DMT. And there's early trials from Beckley SciTech looking at depression and treating that with DMT-assisted psychotherapy. There is one ongoing trial that I'm aware of using DMT psychotherapy to treat methamphetamine dependence. I think that's in a residential rehab setting in the States. Something that would be, I think, interesting, useful to look at as well. There are other things around potentially like IV psilocin and ayahuasca, which is essentially DMT with um, another a drug like called harmaline, which inhibits the metabolism of rapid metabolism you usually get of DMT in the intestines, so it allows for more prolonged effects, and that's otherwise known as ayahuasca, that people have like taken for a long time in traditional settings. So in the sort of contemporary research in this area, um, there's a fairly kind of set um, protocol for how this kind of therapy is delivered. So this is a picture of our dosing room at St. Vincent's, just one of them. We've got two. We're very fortunate about 3 years ago, 3 or 4 years ago, when we set out in this space to have Temple and Webster donate furniture for us to retrofit these rooms. And as you can see, the whole point is to have a very kind of comfortable lounge-like environment. So we have, Himalayan rock salt lamps, and we've got aromatherapy going on. We've got a toilet really close by. This is really kind of trying to standardize and make the setting of where we actually deliver the therapy and the psilocybin dosing really safe. Um, so that's our room at St. Vincent's. So like I say, it follows this really set formula that's called like a set and setting protocol. And that's really where you give some psychotherapy beforehand before the dose. So in the sort of week or two preceding the dose, to help build therapeutic alliance, um, to help people coming into the therapy to set intentions. What do they want to get out of it? And what are their motivations to change? And also a bit of psychoeducation about what to expect during the day. So, things like if, what are you worried that might come up? And, how to, if they do come up, how do you confront them rather than trying to avoid them or run away from them? You'll see some of the results we've seen is around improvements in kind of avoidant type behavior. Um, there's about for our study we did three preparatory psychotherapy sessions, but it's kind of varied across trials how much people get. Then people come in on the dosing day pretty early. They have a few more checks done just to make sure they're in a good headspace. And we required that they hadn't used any meth or any other drugs for 48 hours prior to the dosing. And they didn't have any features of intoxication or withdrawal from any drugs on that dosing day. The main thing that we required is they just had a really good sleep after the sort of last use of meth. And then, after it was all sort of determined that they were in a good headspace, then they were given a dose of 25 milligrams of psilocybin in our study, and then just advised to like lie down on the sofa, put an eye mask on, and we put like a curated playlist that takes the playlist actually sort of takes them through, kind of mirrors the experience of the psilocybin, where there's a bit of sort of introductory kind of while they're waiting for the effects to come on, then it gets more and more intense, the music, and during the peak kind of psychedelic experience, which happens about sort of 1 to 3 hours, the music's the most intense, and then it kind of tapers off and tails off as the psychedelic experience does the same. After that, we get them back the next day usually to talk about their psychedelic experience, try and make sense of it in terms of the goals they set themselves and in terms of their motivation to change. And then we see them again a week later, and that's all really about sort of care planning and next steps. We required all all of our participants to already be having some kind of like therapy or counseling um, for their drug use before they came to our study. And so we were very careful to take handovers from those community-based therapists if they weren't in our stimulant treatment program already. And then we were very careful to hand back to those providers afterwards to make sure the people are well supported. But I'll talk a bit more about our trial in a minute. So, just to give you a bit more of a perspective on what's actually going on in the space of psilocybin-assisted psychotherapy. Um, so in terms of, what indications people are looking at. So this is a bit of a word salad where the size of the words are proportional to like how many studies have been done in the area. So you can see for psilocybin-assisted psychotherapy, most research is in the area of treatment-resistant depression, major depressive disorders, and end-of-life anxiety and depression. That's in like palliative care settings. Like you can see there's been some work done in substance use disorders, but not as much, and certainly not as much in this country. And then there's been a spattering of work done on things like obsessive compulsive disorder. There's some studies going on for eating disorders, and also some for chronic pain. So zooming in on depression, like what's been done there? Well, pretty advanced actually. So there's a number of randomized controlled trials now that have been conducted, um, along with some waitlist controlled trials. You can see here in this table all the things that have been published. And I'm just really going through the sort of more recent history of, because the previous presentation I talked a lot more about the history of psychedelics. But you can see here a number of trials. The interesting thing here is that you can see that for the controls, there's been a variety of different controls used for the dosing schedules. There's been a variety of different like kind of number of doses and actual doses given. Mostly it's around the 25 milligram mark though. And there's been a number of there's some consistency, but a number of different psychotherapy schedules. So one of the issues in general in this area is being able to compare across trials when we're thinking about outcomes. However, there's enough similarities to be able to compare, I think. However, this really speaks to one, it's a complex intervention, and two, it's very hard to design trials in this area. Sorry. Very hard to design trials in this area for that reason, and also for some other reasons around blinding difficulties, which I'll talk about. So really, just to emphasize on a meta-analysis of those depression studies, it really did seem to be effective when you compared it to like the placebo. The only study that really compared it to an antidepressant like escitalopram was the Carhart-Harris study there at the top. You can see maybe slightly less impressive than the other study results. And actually it forces you the big, there's a big spread of results there. You can see the bottom line there, 42 days, and actually didn't quite achieve significance at that level. There's multiple sort of questions around why that is, and if anyone wants to ask me about that at the end, about that, I'm very happy to answer that. So what's going on in substance use disorder? Well, unfortunately, not an awful lot more than when I last talked to you, but I'll run through what we do know. So there's been a trial of, there's been a meta-analysis of studies looking at using LSD for alcohol use disorder. A lot of those predominantly were published in the 70s. And what it essentially showed was that you got pretty good improvements in drinking and heavy drinking days at 6 months. But a lot of people tended to relapse at about 12 months. Now, most of these interventions were either a single or maybe two doses with limited follow-up. And as I said, because most of them were published in the 70s, there's some question around, whether contemporary treatments whether these effects might be greater in the setting of more contemporary treatments that might be slightly better for alcohol dependence these days. And whether LSD was the right sort of way to go, and whether um, you know, whether we could improve on those figures at all. So in terms of other alcohol studies, there's been a lot of work by a group led by Michael Bogenschutz in the US. And this is a small open label study of 10 people that he did initially, looking at, you can see here in this graph at the bottom right here, looking at percentage drinking days and percentage heavy drinking days. And you can see here, uh, even before the first dose of psilocybin treatment, there was a bit of a drop in that anyway. And you usually get that in trials because, people enroll and they're already kind of getting ready to get better, and there's a bit of regression to a mean there as well. But you can see there, after the dose of psilocybin, pretty impressive drops in heavy drinking days and drinking days. And they were sustained out to 36 weeks. But that's only in 10 people. So he then went on to perform a bigger study, a randomized controlled trial of around 100 people, where they randomized people to either 2 doses of psilocybin with psychotherapy, or diphenhydramine, which is a sedating antihistamine. And again, what you see there is, the graphs A, B, C are percent heavy drinking days, percent drinking days, and drinks per day. And you can see there, again, statistically significant drops in all of those outcomes. The table 3 there at the bottom right, I think the thing to focus your attention on there is the number needed to treat. So, to achieve abstinence at 36 weeks, it was about 4 or 5. And to look at to achieve like reduction in heavy drinking, it was kind of around a similar amount. So this trial has had a couple of criticisms in that the kind of people they're recruiting at baseline weren't necessarily daily drinkers. Often they were only drinking like just a few times a week. So the question is how applicable this is to our population of people who are drinking heavily every day, which is the kind of treatment population that's most in need. So I think there's a real need to repeat this kind of study, looking at a heavier drinking population. There's also, well, anyway, I'll talk about other things in a minute. So there's some other work been done, old work now looking at LSD therapy in people who have opioid use disorder. And, like I say, it's published in the 70s there in a residential rehab facility. There's more ongoing work on that at the minute, but nothing published yet. But you can see there, from this old study, again, pretty convincing reductions in opioid use there. Also, I think one thing that's often neglected in our area is smoking cessation. It's really the biggest driver of morbidity, mortality of any, I think, substance. So there has been some good work on psilocybin-assisted psychotherapy looking at smoking cessation. This is a study that's published a few years ago now. Again, open label, single arm study, but with a follow-up of around 16 months or more, that found basically of the 15 people they did get through treatment, 9 had still not smoked since then. A pretty prolonged follow-up. So it's pretty impressive results for that. There are randomized controlled trials ongoing of smoking as well. So sort of alluded to the fact that there's some challenges in conducting these trials, but yeah, you can see here one of the greatest hurdles is in a randomized controlled trial, like how do you blind people from the fact that they're having like a psychedelic when the effects of the psychedelic are so unique and strong? Um, so really, there's some unique challenges and questions for psychedelic assisted psychotherapy and trial design. So what we're seeing is because it's so hard to blind and choose a control group that's active enough so that people think they might be in a psychedelic group, and we haven't found anything really ideal to date, then there's really high rates of people knowing they're in the psychedelic group, and I guess that has a couple of effects. One is that we see a lot of um, kind of disillusionment if they know that they're not going to get an opportunity to have experience with a psychedelic, and that can actually make the primary condition that we're looking at worse. So, if it's depression or drug use, so it can make the placebo arm look even worse, um, which is a problem. Or people just drop out. And again, that causes a problem because it's like there's a selection bias there. Um, so I've also alluded to the fact that it's a complex intervention. So, the questions around what is the right dose, modality, um, and type of psychotherapy. Um, there's been a lot of variation in the sort of results that have come out of a lot of these trials, and I think really a big driver of that is the type and quality of psychotherapy that's been given. So there's a real sort of difference in some trials that sort of really are just focused on safety and psychoeducation versus other trials that are really very much delivering depth psychology. Um, and then there's the dose of psilocybin, and the number and timing of dosing sessions as well. So, really, there's not, um, you know, there's not an awful lot of standardization of those across studies because we just don't know what the answer is. I've got some ideas of what it might be, but again, it's a bit sort of hypothetical. And I think ultimately, one of the largest challenges for this area is going to be, is this good value for money? So the way the therapy is given at the minute is that every therapy session, including the 8-hour dosing sessions, are supervised by two therapists. So you can imagine that's an awful lot of therapy hours. So again, it kind of depends what you're comparing it to. If we're thinking about methamphetamine dependence, then do we compare it to residential rehab or do we compare it to 4-session CBT? So it's and how much more effective is or not is this treatment potentially going to be? So I think there's real questions around, ultimately, if we want this treatment to be publicly subsidized, like, is it going to be, is it actually good value for money? And then there's some larger questions there. Are two therapists actually required? We have them at the moment for safety reasons during the and some practical reasons as well. So during the 8-hour dosing session, people are in a really vulnerable state. So it sort of helps to have two therapists there so they can monitor each other and the patient. And, people need to go to the bathroom and eat and things like that. So it's useful to have some redundancy. But the question is, do they need to be there all the time? Some groups have questioned whether psychotherapy is needed at all. And there was a search amongst pharmaceutical industries for drugs that produced produced a lot of the changes in neurobiology that you see with psychedelics, like neuroplasticity, but didn't have the psychedelic effects. And that search is still ongoing. And there's been some interesting studies looking at giving people psychedelics under general anesthetics to see whether they still get some of the sort of therapeutic benefits, to see whether you actually need to have a subjective psychedelic experience at all. And then there's, questions around microdosing. So, um, and I'm involved with a randomized controlled trial of that for depression based out of Macquarie University at the minute, around, is that useful and how and why? So thinking about this area, I think it brings up some really interesting questions around, um, you know, our understanding and diagnosis of mental health problems, and I think what it's sort of causing is a bit of rethink of these kind of syndromic diagnoses that we recognize in ICD-10 and DSM-5 kind of criteria. I think ultimately we're moving towards more of a kind of neurobiological approach to mental illness anyway, um, in that, I'm kind of recognizing that it's a really sort of also a psycho and social kind of concern as well, but recognizing that there's commonalities to a lot of these conditions, including mental health and drug and alcohol, that psychedelics seem to be helpful for. And so this kind of summary of things that, like common things that happen across these conditions that, might be addressed by psychedelic assisted psychotherapy. So, generally people struggle with mental flexibility. So their ability to think in shades of gray rather than just black and white concrete thinking. Um, People often have lots of sort of ruminating type thoughts and become very fixed in thought loops, um, or beliefs. And that's kind of thoughts or beliefs like about the world, that it's a dangerous place or a bad place, or themselves, and thinking a lot about the past or the future. Um, Decreased social connection is a really common phenomenon associated with like all of these conditions, like particularly sort of depression and addictions, and decreased mentalization, so decreased ability to be able to put ourselves in other people's shoes and um, you know, imagine what they're thinking. And so, yeah, in terms of the phenomenology of the psychedelic experience, you can see here that what's been described is a sense of connection, intuitive knowledge about the world and about, often heightened empathy for other people, transcendence of time and space, and deeply positive mood, paradoxicality, so ability to like be flexible in your thinking, like hold like contradictory things in mind at once. So you can see how like, the phenomenology of the psychedelic experience might lend itself to psychedelics, to this to these conditions. So there's other sort of interesting work looking at, why serotonin receptors, why 5-HT receptors. And so there's some interesting article published by Robin Carhart Harris a few years ago, looking at why antidepressants that work on serotonin receptors might be different to psychedelics that work on serotonin receptors. And they really sort of try to drill down to, well, antidepressants probably work mostly at 5-HT1A receptors, whereas psychedelics work at 5-HT2A receptors predominantly. Why is that important? Well, 5-HT1A appears to be a pathway that's associated with passive coping. So your ability to just tolerate distress, to sit with it, but not really to do anything about it, just to be with it. But it doesn't motivate you to necessarily make any changes, to adapt your environment, to actually sort of make things better. Whereas 5-HT2A pathway is very much associated with active coping. So making adaptations to your environment to actually to get into recovery. So, what that might look like is trying to make new connections, social connections, trying to like improve your situation, your sort of relationships or like your work situation, whatever. So this to me is like opens up really fascinating possibilities as well. So there's been a lot of attention recently on what's actually going on in the brain to give us um, a conscious experience. So how, like in terms of what we perceive and how we perceive the world. So there's been a lot of work that's kind of been in parallel with developments in artificial intelligence on understanding this thing called hierarchical predictive processing. And this all happens in the cortex, the cerebral cortex in the brain. Um, and so, really, the theory is that most of what we perceive is actually based on models of the world that are formed in the brain. Um, and particularly in the higher levels of the cortex. Um, so what's happening with our senses, like our sight and sound and that kind of thing, is they're not necessarily forming the conscious experience. They're just um, helping us reality check or error check our predictions of what we think is going on, and that's what conscious perception is in reality. So, in fact, most of our perception is fed to us from our cortex about what we're expecting to see in a particular situation, and that's just error checked with sensory input. So, what's a model? So it's everything from as simple as sort of lower level things like that's a line or that's an edge, to slightly higher level things like that's a table or that's a tree. So very high level things like this is a model of my sense of self, or this is my model of my sense of other people or the world. Um, so each model that we have is weighted by how confident we are that that's a true representation of reality. Um, so beliefs are just one form of, like in this theory, beliefs are just one form of model. And so some beliefs we hold very strongly, and some we hold more lightly. So the beliefs that we hold very strongly, it's actually very, very hard to change your mind around those. Um, so if we can somehow get at the weighting system that allows us to like either lessen or lighten certain beliefs or models that we have of the world, then that theoretically might allow us to kind of have more reliance on our sensory input, our kind of our other sources of input from the world to kind of reality check what those beliefs might be. So, for example, if from very early in life, when a lot of our beliefs are being formed, we were led to believe, or we formed a very strong belief that the world is a bad place or a dangerous place, or I'm a bad person. Then, that strong belief is very heavily weighted and colors everything that happens, all of our perceptions, and all of our kind of cognitive biases that happen from then on. So the theory is that psilocybin acts through 5-HT2A receptors in the cortex to really lighten this weighting system that we have on all of our models, but particularly our beliefs. And the therapy allows us to then, more kind of theoretically sensory input to enable us to sort of adjust those beliefs to like a more helpful belief system. So if you kind of take this system, this hierarchical predictive system, it actually does apply to a number of other different pathologies. So schizophrenia has been hypothesized to be a dysfunctional precision weighting um, system that where like psychosis is driven by noisy prediction errors. Autism is probably the opposite of that. So like problems with not weighting enough, an excessive focus on raw sensory data, inability to model other like emotions or other people's like feelings. And depression is a really sort of dominant weighting of negative priors, negative beliefs about the world and yourself. Um, so as I said, like I think we're moving. I think there's a move beyond like syndromic diagnoses in mental health to more diagnoses related to what's actually going on in the brain at the time as well. And so we know that there's a number of brain networks that work together to achieve certain things. Um, and so, so I'm just, so one of the three most important brain networks in addiction are the default mode network, the executive control network, and the salience network. There's also the limbic system, which or the limbic network, which we sort of commonly associate with addiction. But these three networks are very important to help us. So a default mode network really gives us a sense of self. So it's our network that comes online when we're just sort of in idle mode. But really what we're doing is, having an internal monologue, thinking about the future, and mental time travel into the past as well. And that all gives us like our sense of self. Um, and what we know is in addiction, like for example, methamphetamine, um, people who use methamphetamine, their brains have decreased connectivity in this area that's associated with like impaired insight and increased impulsivity. There's also decreased connectivity and executive control networks, and and that sort of gives poor executive function, like what we focus on, and poor inhibition, our ability to say, "Oh, like stop." I don't think, I don't think that's a good idea. I don't want to go down that path. And the salience network, which is really sort of what's detecting and focusing on what's important in your immediate environment. That's sort of, dysregulated in addiction, and that's associated with enhanced drug-related cue reactivity. So, when you see something associated with a drug, that lights up, and cravings as well. So there's been big changes in Australia recently relating to like psychedelics. So last year there was a rescheduling of MDMA and psilocybin. So now these drugs are on prescription through psychiatrists to treat for psilocybin to treat treatments with depression, MDMA to treat PTSD. But given this has already started, I think it's probably a matter of time now until it's, for um, rescheduled for other indications. So, what implications does this have? Well, it means that you can theoretically see a psychiatrist to have these medications with psychotherapy. The problem is that it's so expensive to deliver, and it's so much really restricted to the private sector now, that it costs about $10,000 to $20,000 to actually have these therapies. So that really is a sort of real equity issue and provides and there's a lot of barriers to actually people getting these kind of treatments. So, I think one of my goals is to try and investigate, well, are they really effective and safe? And if they are, can we get um, equity of access so that people who really need it, who are often the ones that can least afford it, actually have access to it? So in Australia, it's regulated through this thing called the Authorized Prescriber Scheme. So it's got to be under psychiatrist supervision. Um, the process is that the psychiatrist has got to get approval from a protocol approved by a Human Research Ethics Committee, and then got to go back to the TGA to get registered as an authorized prescriber, and then go back to the and then has to find a supplier of either local or imported supplier of a psychedelic, and then has to get state-based license to actually provide that. So, given there's so many steps and it's like administratively very hard, like there's not a lot of prescribers, growing number, but not a lot of prescribers currently in the country. So now I'm just going to step you through some of the research we've been doing. So I work for the Poison Centre, so we did some research looking at calls to the Poison Centre relating to psychedelics. And as you can see here, there's a graph on the bottom right from 2014 to 2022 related to number of calls broken down by type of psychedelic. And you can see just since like 2019, when really I think there was increased public awareness of like some of the research into psychedelics, and they were becoming a lot more popular to use recreationally. We saw this big uptick in calls to the Poison Centre, and they were mostly young males and intentional ingestions. pretty commonly ingested with other things like alcohol, cannabis, and MDMA. One of the markers of like severity of like poisonings that we have for the poison center is like of the calls we took, how many were either referred to hospital or actually taken, the calls were from hospital. Um, and that was 85%. So that's pretty high, much higher than a lot of other substances we see. And so, even though we think psychedelics might be safe in a controlled setting, this kind of is a signal that in uncontrolled settings in the community, maybe not quite as safe. We did see about 3% of exposures that were just to a psychedelic had seizures as well, which was a bit of a surprising finding. Um, there may be some other things going on there that, the person might have had an underlying seizure disorder, but that was definitely a safety signal as well. So talking about methamphetamine now. So I think, within this audience, probably don't need to talk too much about that, but in summary, it's Australia has one of the highest prevalences of methamphetamine use in the world, and it's really in terms of rates of dependence, it's a sort of growing issue. You can see here on the graph on the right, which is data from the AIHW, the prevalence of methamphetamine dependence is increasing every year. And there's a number of harms associated with meth dependence, cardiovascular disease, increased risk of HIV, Hep C, and death. It's the most common illicit drug that's been in Australia that people seek treatment for, but there's really very few effective treatments. So there's no pharmacotherapies, and so psychosocial therapies are difficult to access. There's high dropout rates, and actually lots of barriers to care as well. So it's a methamphetamine use disorder is a big sort of unmet need there for treatment. So we got together with a group of people internationally who are interested in exploring psilocybin-assisted psychotherapy for meth use disorder. And we published this paper in Frontiers in Psychiatry. And really what we sort of laid out there was like, one, before we did anything, it was probably good to understand what people were doing in the community already, like people using meth. If they use a psychedelic, what kind of experiences were they having? Some of the things we're a bit concerned about was like because meth and psychedelics kind of work on similar receptor systems, whether people who use meth regularly might not get as full a psychedelic experience. And you might need like bigger doses of the psychedelic to achieve similar effects as like people who weren't using meth. So we call it dose blunting. Um, People who use meth, depending on what population you look at, have much higher rates of high rates of stimulant-induced psychosis. So, from anywhere between like 15% to about 50%. Problems with trials with methamphetamine depends with study dropout, which was, a big problem when you already might have dropout from issues with masking in these studies. So first thing we did was we did a big survey looking at people who are regularly using methamphetamine, but also had recently used psychedelics. And what we're trying to get is like, what do they look like? Um, what other kind of comorbidities did they have? Like, and what kind of experiences did they have from the psychedelics? And then, what were their outcomes? So what we found was that it was an international study, and what we found was this group had high rates of mental illness, suicidality, and psychotic symptoms, and they used quite a lot of other substances as well, particularly other substances used at the time of the psychedelic. Mostly it was unplanned and recreational. Um, but even given that, 50% had improvements in their mood and social functioning, and about a third reported reductions, sorry, in their methamphetamine and other substance use. So, even despite high rates of mental illness, poly-substance use, and unplanned use, some people were still having pretty positive effects, but around a quarter had negative outcomes. And I think, it's not that surprising to me in these environments where, people have other mental health problems and like the using other substances in sort of potentially chaotic recreational environments. You're going to have people who have, some bad trips, and their mental health and substance use gets worse. So interestingly, good outcomes were associated with less challenging psychedelic experiences and pre-planning. Pre-planning, I think we can understand because that's then you're probably curating your sort of the setting and maybe your headspace a bit more. Less challenging experience is interesting. I think the what we see in trials is, and I'll talk about this, is like it's useful to have like a bit of challenging, a bit of a challenging time when you're having a psychedelic, but not too much. We'll talk about that later on. We also did another survey study looking at, well, acknowledging that so many people were using psychedelics who might have other drug and alcohol concerns, um, and really exploring whether there was a need for people who had used psychedelics naturalistically, to have any support after that use. Did they have such a bad trip that they needed to talk to about someone, or was there unrealized therapeutic potential there? As in, if they had chance to talk to someone about their experiences, would that have helped them along the path to like making changes they wanted to make? And actually, like overwhelmingly, people said like they did want further support. We looked at people with substance use problems and had used a psychedelic, and overwhelmingly, people said like they would have liked further support following the psychedelic experience. And about two-thirds said individual. Again, there was sort of a bit of an even split between wanting support from a psychologist or a peer worker. And around a quarter are interested in some group-based therapy as well. So that's something that I think we'd love to explore more in terms of, and I think there's already groups set up in Sydney to help support people in this sense as well. So finally getting to our study and what we did. So we recruited 15 people with meth use disorder. Initially, we started recruiting people who were using less than 16 days in the month, but after 3 participants, we relaxed that to any amount of use in the month. And for those that required withdrawal management, we did that. We put them through withdrawal management as an inpatient. We looked at safety, feasibility, but a number of other outcomes related to meth use, quality of life. And we did brain scans before and after as well, and a qualitative study as well. So as I said, after assessment, we did some preparation psychotherapy. We did 3 sessions, gave them 1 dose of psilocybin, and then 2 more integration sessions after that, and then followed them for 3 months. So these were the study results. So we did online screening of about 56 people. We screened of those 16, and then 15 were allocated to this single arm intervention. So there's no control arm. And of those, we're able to like dose and then follow 14, which we're pretty happy with. You can see here the breakdown of like demographics of people who are in the study. You can see here again, most people male. There was quite a large number of 40% were identified as gay or lesbian. Fairly highly educated and fairly sort of full-time, like 60% full-time paid employment. And most people smoking. So you can see, I guess there's questions around. So this is probably like a kind of maybe a slightly lighter using population who might just use sort of long weekends and then also have a job. So in terms of safety, no serious adverse events. There was some treatment-related adverse events that were 6 that were pretty mild. They were all mild or moderate, and all self-resolving. And the commonest was nausea and headache. And you can see here, this is heart rate and blood pressure measured during the psilocybin dose, and there were no concerns there at all with any of those vital signs. In terms of the psychedelic experience, we measured mystical effects. So this is like a measure of like intensity of psychedelic experience according to these various domains using validated surveys. And you can see here, the kind of what we look at is like the percentage of maximum score along the bottom there on the left, and that's out of 100. And if you get over 60% on all those domains, then you're looking at a full psychedelic experience. You can see there people were having mostly full psychedelic experiences. So there wasn't, with 25 milligrams, there wasn't any issues with dose blunting. And on the right there is the challenging experiences. So that's like a kind of adverse effects again of, psychological problems from following the psychedelic and really minimal, low level problems there, very comparable with other trials looking at psychedelics. So we're pretty happy with that. Um, Really, in terms of meth use, this is really just speculative because it's a single arm open label study. But what we saw is on the left there, you can see a graph where we measured, it's called timeline fallback. And we counted the number of days in the last 28 where people had used meth. We measured that at various time points. So we tried to measure that at baseline and then before they had their dose. So before psychotherapy and before the psilocybin to see whether it was just an effect, like any effects of like just recruitment and the preparation psychotherapy. And you can see there, no, it wasn't like any of those effects. It was pretty stable at baseline. But then we saw big reductions at day 28 and 90 post treatment. And, really to a median of 0 days, day 28 use in the last 28 days, and 2 days use at day 90. So really substantial drops in methamphetamine use. We saw similar things for methamphetamine craving. There you see the graph on the right. And also, graph on the left here it shows improvements in quality of life out to 90 days and improvements in measures of anxiety, depression, stress out to 90 days as well, albeit like very large interquartile ranges there because it's a small population size. So we also did qualitative experiences before and after um, uh, the the treatment, and really what people described was pretty rich experiences of like new self-understandings and new perspectives on the world. So being able to zoom out and put things in perspective, particularly around sort of traumatic memories. Um, and real, like as expected, experiences of connectedness, acceptance, and self-compassion. And along with this was experienced through like really vivid imagery and kind of journeys. So and people described loss of a fear of death, and they're being stardust, like really thinking about that perspective as as being a small part of the universe. So a theme that really came out very strongly was this sort of idea of like um, being presented with some kind of obstacle or some kind of challenge that they weren't necessarily aware of in their kind of day-to-day lives, and it was implicit that what they were presented with during the psychedelic experience that was often related to um, early life attachment traumas. So like, parents separating or being abandoned by parents, things like that, that had led to like guilt, grief, shame. So you could think about like, really strong weighting models, prior models of the world. And so what their experience was of being confronted with that, and then instead of avoiding it, running away, like leaning in and sitting with it and finding some kind of love and resolution around that, like catharsis, reframing, understanding from different perspectives. And actually, once that had happened, so very rarely it was about meth use. And once that had happened, the salience or importance of meth use in their lives really was massively reduced. Won't talk too much about this, but we've got some pretty exciting results from some functional magnetic resonance imaging on changes in brain network activity. That's exactly what we expected to see, which is nice, which is consistent with other neuroimaging studies where we see um, increased connectivity between all these cardinal brain networks involved in addiction, and increased connectivity with the rest of the brain there. So we'll be writing up those results soon as well. So what next? Well, given the such promising results here, I want to do a much bigger randomized controlled trial across multiple sites, and we're applying for grants for that. But if anyone knows any rich philanthropists who want to give us money to do that trial, then I'm happy to be contacted. Um, how can we make this potentially more cost effective? So we're looking at trying to get funding to do models where we do group work, group therapy, and maybe even group dosing. Um, do we need like two therapists all the time? Again, it's sort of good to unpick that. And I think I'd be keen to investigate other types of psychedelics like DMT, psilocin, and ibogaine. Um, so like with all these research projects, it takes a village. And so I'd just like to acknowledge NCRED, who provided us with a lot of financial support and ongoing support, the Black Dog Institute, who we're collaborating with, and St. Vincent's Clinic, and the Curran Foundation, and all these people here who've really been instrumental in helping us with this research. So yeah, happy to answer any questions.
Cool. Thank you so much for that, Jonathan. Very interesting, very promising results. I'm conscious of time, but there are a few questions if you're happy to hang around for a few more minutes.
Hmm.
I'll start with some easy ones first, just around kind of the process. Is the psilocybin administered in a powdered or capsule form? I think people are interested. Yes?
Yeah, it's just a capsule. It's imported from a company called Usona that's based in the US,
Right.
and it's made in the lab. Yeah.
Yeah. Awesome. There was a question around psilocybin and potential contradictions for heart conditions and
Yeah.
whether that was considered, particularly, I guess, with methamphetamine use also being
Yeah. I
severe
think
toxic.
people would have to have pretty severe like cardiovascular issues like heart failure or like really poorly controlled heart failure. There's been a big study done down in Melbourne by Marg Ross looking at end of life palliative care, and they've those people with pretty advanced heart disease and heart failure in their studies, and it was pretty safe. So I think the conclusion is it's pretty safe. Yeah.
Thank you. I think you might have covered some of this, but one person talked about a client whose use of mushrooms, I guess, naturalistically elevated perhaps fixed beliefs, particularly around electromagnetic fields. Is that, yes.
Yeah, absolutely. So really, I think the current thinking is it really should be avoided in people who have any risk of primary psychotic disorder.
Mm,
So people who've got a history of bipolar, schizophrenia, or any first or second degree relatives with the same.
mhm,
We've been we excluded people with a history of meth psychosis. I
mm,
think that yeah, there may be some sort of a you know, I think I'm interested to sort of see whether it's safe in people who've just had very limited meth psychosis lasting 24 hours and then it resolves.
mm.
I suspect it probably will be, but really try and avoid in anyone with any kind of psychotic problems at all at the minute.
Yeah, for sure, for sure. There was a question around the survey data where there was significant reduction in methamphetamine use. Was there increased use in some of the survey as
Yeah,
well?
so some people reported increased use.
Yeah.
Um, and that could either be my gut is that like this is a really sort of unfiltered population that are frequently taking like psychedelics in like you know uncontrolled situations where they have like other mental health problems like psychosis and other drug use. So I reckon that's probably part of the reason they're having bad trips, and then that's leading to like increased drug use. Yeah,
Yeah.
is the most likely explanation.
Thank you. Quickly on in terms of the type of psychotherapy used, is there a
Yeah,
particular?
so it's unclear what the best modality is. I think the most people follow like a baseline formula of like the set and setting approach where, psychoeducation, building a therapeutic alliance and setting intentions is the basic thing. What you layer on top of that is, it's kind of variable. We used a combination of like motivational interviewing and acceptance and commitment therapy, which seems to fit really well with drug and alcohol because it's already sort of been researched a lot with that and been used with that in the past. So that's what we used. Yeah.
Yeah. And were some of the participants happy with the setting in terms of indoor versus outdoor or choice of music? How did that?
Yeah. Most people were pretty happy with our music choices. Um, I think the main things to consider are like access to a bathroom,
Mm,
and easy access to that. Would people have liked it outdoors? We didn't specifically ask them that actually, but
yeah.
informally, I think yes is the answer. It's more difficult to control those settings, but
Mm,
like I'm aware of a study in New Zealand looking at indigenous Maori populations that are doing this research in a sort of more
Mm.
uh, outdoor setting, like a more naturalistic setting, which is really great.
Yeah. Are participants required to cease other medications such as antidepressants?
Yeah, so generally that's what we'd recommend to be like at the
Mm.
moment. Yeah, there's some emerging evidence to suggest that it might not be necessary in all cases, but at the minute, the prevailing kind of advice is to, that they need to be stopped. Yeah.
Yeah. And I think you mentioned earlier when there was a drop prior to even the first session of the psychedelic therapy, but does
Mm.
expectation or expectancy theory kind of impact, like people who believe it's going to work are more likely to have better treatment outcomes?
100%.
Mm.
Yeah. So,
How do you, yeah.
well, in fact, this modality seems to be an accelerant of expectation. So,
Mm.
expectation is actually part of the therapeutic effects that we hope to leverage. I mean, how do you separate the problem is it's very difficult to separate out in these studies expectancy from true drug effect or true like treatment effect
Mm.
because expectancy is so much part of the treatment effect. So, that it comes to like trial design and like, masking and things like that, but I'm not sure we'll ever know the answer to that. Yeah.
Yeah. A lot of interest in the music. How did you choose the music?
Yeah, right. So we were pretty fortunate that we had like Mark Ross and her team I mentioned down in St. Vincent's, Melbourne, had already worked with a musicologist to develop a playlist. It's
Mm.
mostly world music. There's
Mm.
been, but so our current study we're doing is on treatment-resistant depression, actually leaving people on their antidepressants and dosing on top of psilocybin on top. And for that, we're looking a bit more at music. So we've chosen 5 different playlists that are so kind of subtly different. And
Mm.
we're getting people to more sort of compare and contrast what was helpful across those playlists. But there's a lot more work to be done there. Yeah.
Yeah. Look, I think that covers most of the questions that have come through. Oh, people want to know if the playlists are available. So,
Yeah, there's some publicly available ones. Yeah, yeah,
yeah,
yeah.
okay.
I think
Share your Spotify
we
link.
can find them. Yeah, they're mostly on Spotify, to be honest. Yeah, but if anyone
Yeah,
specifically wants to contact me about that, I'm happy to share what I can. Yeah.
yeah. Not a problem. Thank you so much, Jonathan. That was very fascinating, very interesting, and it's good that you explored some of that historic research as well, contextually, not just around methamphetamine use and dependence. So thank you so much once again to all of our people online. We're over 100 people there today, so a lot of interest. Thanks for your questions and your comments. We're having a slight break now because it's our show day next Wednesday here in Brisbane, sorry, the rest of Queensland. So we'll be back on the 20th for our next webinar. Please fill out the evaluation if you can. And thank you once again, Jonathan. Really appreciate your time and wisdom and insights today.
Pleasure, pleasure. Thanks, Jeff.
Thanks, everyone.